DAROGA Postpartum Hemorrhage Part 2. In Part 1 we discussed the prevalence of maternal mortality due to, in particularly postpartum hemorrhage, and we discussed the general principles of how to manage a lady with hypovolemic shock despite the cause, regardless of the cause. And here today we will focus on the following topics: the specific postpartum hemorrhage management after we performed the resuscitation Dr. ABC. And we will use as often 4 points of focus. First is the tone of the uterus, or the lack thereof. 2 is tear or trauma. 3 is tissue. And 4 is thrombin. And we will see that this is quite helpful in a systematic approach of dealing effectively with postpartum hemorrhage. And I will finish, as you would expect, with a summary. I love trees. I have a fascination for old trees, but a tree structure is also quite helpful for learning, as I will try to explain to you. We are dealing here with the stem, the trunk of antepartum hemorrhage. And firstly, we have a number of issues. The most common cause of postpartum hemorrhage is lack of uterine tone. So that's the first focus point. Secondly, tear or trauma, somewhere in the genital tract. It could be vulva, vagina, cervix, or even uterine rupture. Tissue, in principle, there is retained products of conception or an incomplete placenta, which are still inside the uterus. And the fourth course we need to think about, and is the least frequent one, is problems with clotting, thrombin, the fourth T. Let's go to the first T, the tone. All items on the left-hand side will have to do with mechanical measures we can take to try to promote contraction or compression of the uterus. The horizontal line, below the horizontal line, measures we usually can take in the labor ward or in the birthing suite, and the first one, mechanical, is rubbing up the uterus, bimanual compression, or reposition of the inverted uterus. We will explain that further into detail and some pictures later on. In operating theatre, we have options to place an intrauterine balloon, the Vascular balloon, which will give compression from within the uterus, or we can place the B-Lin suture. This will require a laparotomy or a relaparotomy in case of a lady post-cesarean section. Very important to realize that this picture is the main culprit. The uterus here is atonic, is not contracting, there's ongoing bleeding from the placenta bed, and clots are inside the lower uterine segment. So as a first measure, if a lady is bleeding, we should automatically rub the uterus up, trying to compress the uterus, promote the uterus to contract down, as is depicted here in a picture I took from an old textbook. By the way, important that after the placenta is born, we check the fundal height regularly, and we check that the fundus, the uterus, is firm. In other words, the uterine muscle, the myometrium, is contracted well. That's why in some parts of the world they like to use a 4th stage of labor. That means 1 hour after the placenta is born. And indeed, vigilance after the placenta is born, keeping an eye on the blood loss externally, but also on the contraction of the uterus. And the uterus usually should be 2 fingers below the umbilicus. That prevents further bleeding due to atonia. At the same time, whilst wrapping up the uterus, we would, and we have established already IV access, we would administer a Uterotonic either intravenously, or if you don't have IV access, or you would have a delivery at home, one could give 10 units of syntocinon intramuscularly. So this is now the part of tone, the medical management, Uterotonics, all drugs which promote contraction of the uterus, and we have 3 groups. The oldest one we use is ergot alkaloids. The more recent one is oxytocics, and the last one detected were the prostaglandins. And we have a few examples: oxytocics, syntocinon or carbitocin, ergometrin, prostaglandins are misoprostol, or prostaglandins F2 alpha. So here you see an overview of the uterotonics we can use to deal with lack of tone of the uterus. Let's zoom in and we now look at the leaves of the tree, if you like. We have IV oxytocin, also called syntocinon or pitones, 10 international units and or 4 international units in 1 liter in 250 milliliters of normal saline per hour. The half-life of oxytocin IV is very short. It works only for half-life is only 3 minutes. We can also use an oxytocin equivalent, but that has properties of a slower release of a longer half-life, carbitocin, which can be given IV or IM, 100 micrograms, and we use it in our practice mainly for PPH prophylaxis after caesarean section. So as soon as the baby and the placenta are born, carbitocin is administered. So it works a bit longer than the oxytocin drip we usually use. The third group is the ergot alkaloids, ergometrin, 500 micrograms per milliliter, given intramuscularly or IV. Whilst this drug is quite effective in contracting the uterus down, it has also a vasopressor effect, and should be given with caution or not at all in case of hypertension or preeclampsia, and it has most certainly a side effect of nausea and vomiting, so not very pleasant for the mother. We can also give symptometrin with a combination of 5 international units of syntocinon, oxytocin, and 500 micrograms of ergometrin with a half-life of 30 minutes. So if you look at the side effect profile, syntocinon, oxytocin is the most pleasant for the mother. Other uterotonics, the prostaglandins, misoprostol, that's a PGE1 analog, 100,000 micrograms or 800 micrograms. Tablets are 200 micrograms, either orally or could be given sublingually, or even PR. It is useful to maintain uterine contraction. Of notice that it will be metabolized in the liver, and it's very cheap, and it doesn't need to be stored in the fridge or the freezer. That's why it's very useful in low resource countries and has contributed already in a considerable drop of postpartum hemorrhage. Then the prostaglandin F2 alpha, 5 milligrams per milliliter. That should be administered directly in the myometrium with a long spinal needle through the abdominal wall in the muscle of the uterus, or deep intramuscularly. This is the most potent uterotonic we have available at the moment, and it's very efficacious as well in a shocked patient. We should use that for the second line treatment if we're dealing with a massive PPH. It's also recommended to be used in hospitals only because it results as well in bronchoconstriction, so it should be used not at all or with caution in case of a history of asthma. So this concludes the 3 different groups of uterotonics we have available to deal with lack of tone, atonia of the uterus. Now let's go back to mechanical measures. Another way is to compress the uterus bimanually. You place one hand or fist in the vagina and divert the uterus, and then push both the internal hand and the external hand together, and in this way you compress the uterus and limit the blood loss. You could argue it's almost like a bench vise approach. Be assured, if you do this maneuver for a few minutes, that afterwards you will have shaking muscles, and if you need to do an operation, that's not very helpful at all. So this is a measure you could take when you are alone and you're waiting for help to arrive. So it's just buy some time, try to minimize the blood loss whilst people are on the way to help you. Another very rare condition, and that's depicted here, is a complete inversion of the uterus. Here we see the uterus is from inside moved out, completely outside, and here we see that the placenta and the umbilical cord is still attached. This is a rare condition, and we should think about it when the woman has clinical signs of shock, so hypotension, whilst there is not a large amount of blood loss. So when there is a discrepancy between the shock symptoms and the blood loss, and quite often there is a low pulse rate because of cervical shock, so due to parasympathetic stimulation. So if you find out that the uterus is partly or completely inverted, without delay you should reposition the uterus as is depicted here in this picture. Squeeze the uterus back together. Please do not try to remove the placenta. Squeeze the uterus back together and move it slightly inward and upward back into the abdominal cavity, and eventually with the fist inside the uterus, you reposition the uterus completely. At that stage one could remove the placenta manually and give Uterotonics, and as long as the uterus is not contracted, it's important to maintain that internal control. Another way to provide internal pressure if there's an ongoing bleeding, that is put a intrauterine balloon. It's like comparable to a bladder catheter, but the balloon has now a considerably larger volume, up to 500 milliliters. In the past, gynecologists, obstetricians would pack the uterus with gauzes to give pressure from within, but this is a more contemporary variant. So we can see here the balloon as it should be placed. The balloon is now inflated, sits in the uterus. The tip here can monitor any ongoing blood loss, and you can find out externally. And here we see the cervix. The balloon is nicely placed in the uterus. By the way, when we place this balloon, usually we do this in operating theater, and it's important to do that with ultrasound guidance to make sure that the balloon is placed correctly. Usually you leave this balloon in for 12 hours, deflate it gradually, and usually the bleeding problems are behind us. Then we have a few advanced options which we can use in operating theater. The so-called B-Lynch, it's Bernard Lynch, the doctor who invented this, brace or compression sutures. Here's a diagram to explain this. It's obvious that this lady had a lower uterine segment cesarean section, and you can see here how the sutures are placed across the fundus of the uterus. You go to the back, cross over, come back, and once more you cross the fundus, and then here at the front the sutures are tied together. The suture is tied together whilst your assistant manually compresses the uterus, so these sutures prevent the uterus from expanding or filling up with blood again. Okay, we now move on to the second and the third topic, the second and the third cause of postpartum hemorrhage, which are tear or trauma and tissue. If we have dealt with the tone of the uterus is well contracted, and we have ongoing bleeding, the procedure, the advice is to go to theater for an examination under anesthesia. So to deal with 2 and 3, we go to theater. The patient can be put under general anesthesia or spinal, depending on the circumstances. And we will be able to systematically inspect the genital tract for any tears, which can be sutured. It could be vulva, vagina, cervix. We could remove remnants of the placenta if the placenta or the membranes were not complete. That means we go in with our fingers and check the uterine cavity with our fingers to find out if there's still placenta around. And sometimes we find out when we check the uterine cavity, that there is a rupture in the uterus. That uterine rupture usually means laparotomy, and sometimes we can suture the uterus back together if the damage is limited, but sometimes if there is a big tear, then it means that would warrant hysterectomy. Well, I used the tree structure several times to show you how useful it is to use this tree structure to promote your learning, and most certainly these are not my hands. Whilst I admire trees, I'm not going that far. Okay, management of tear and tissue, examination under anesthesia. We go back to operating theater. We can position the patient optimally in the dorsal lithotomy position. We have optimal light and visualization. We have an extra pair of hands with equipment. And a good thing is that the anesthetist and his team, they manage her vitals, so you can focus on the second and the third T. If there's any lacerations, we can suture them as discussed already. If you find a hematoma bigger than maybe 3 to 5 centimeters, incision and drainage is the way to go. Incomplete placenta can be removed manually or digitally. And if there's a uterine rupture, we have to proceed with a laparotomy, either suture the uterine rupture back together if the damage, the trauma is limited, or proceed with an hysterectomy. Now we move to the fourth T, that's thrombin, issues with blood clotting. At this stage we need to consult with the hematologist to find out what blood products should be administered to the patient to deal with, for instance, the disseminated intravascular coagulation. But nowadays we have a new piece of equipment, which we'll discuss later, the so-called ROTEM, and that gives us almost instantaneous information about the clotting problems the patient might have in operating theater. So what we have to administer is sometimes fresh frozen plasma, cryoprecipitate, or recombinant factor 7A. Tranexamic acid, as we discussed before, reduces the lysis of a clot, is an anti-clot agent. Vascular measures, that's the last group of measures. If despite all measures, dealing with the tone, dealing with trauma and tissue, the patient keeps on bleeding, before we proceed to the definitive solution, which is an hysterectomy, we have a number of options available to tie blood vessels off or to close them off. That's embolization of the uterine arteries, that's tying off the internal iliac artery, tying off or the ascending branches of the uterine artery by the so-called O'Leary stitch. Here we see a diagram of the O'Leary stitch. This lady had a lower segment cesarean section. Here we see the uterine artery, and this is the ascending branch which runs on both sides of the uterus in the parametrium. And when we place a stitch here and there, and do it on both sides, that minimizes, that reduces the blood flow to the uterus and sometimes is sufficient to deal with the postpartum hemorrhage. Then intervention radiology, they could perform a so-called uterine artery embolization. This method is of course not available in many hospitals, only in secondary or tertiary hospitals, but it can be quite useful and can be uterus sparing to deal with a massive PPH. Of course, that's not the case if the patient is, if the situation is life-threatening, but it can be useful. This is a picture which shows the relevant blood vessels. This here is the bifurcation of the aorta, the common iliac arteries. 3 is the external iliac artery, 4 is the internal iliac artery, and here 5 are the femoral arteries. If you tie off the internal iliac artery, you tie off the main branch, of course, going to the uterine artery. This is a method which will, I think, Gynecological oncologists are familiar with tying off this blood vessel. Most obstetricians are not, and we have to be very aware of the risks. If you inadvertently would tie off the external iliac artery, that means the lady will lose her leg. So it's not a common procedure, but it can be done in centers where you have gynae oncologists, vascular surgeons available. Okay, what is new according to Scooby-Doo? And here he is in good company. The first time a blood transfusion was described is in the Lancet in 1828, where you see here a lady who is apparently suffered from postpartum hemorrhage, and this is a male person who directly offers his blood. This is the first time, and it was described by Dr. Blundell as a gravitator. So they used gravity to make sure that the blood from the male person, from the volunteer, went to the probably moribund mother. Nowadays we have the cell saver, the so-called cell saver, and you see here a picture of the one we used at the Iliac Hospital. That means if there is blood loss, we can suck the blood of the patient away. This will be washed and sometimes filtered, and that means we can give back to her autologous red packet cells, which can be reinfused. So that reduces the likelihood of blood transfusion. Very handy, and we use it nowadays almost for every cesarean section. It's standby. It's very cheap. I think just to run the equipment it's $80, so it's very affordable as well. Another method we have nowadays available is the so-called ROTEM Thromboelastography. We can take a sample of blood, and this machine is very clever. It produces a graph, as you can see here. It looks like a bullet or a drop, and immediately it tells you not only on the left hand side, it tells us about the situation, the coagulation properties of blood. On the right hand side it gives us how the fibrinolysis is going, and immediately it tells us as well what we should do. So here, if we in this area, administration of fresh frozen plasma is warranted. Here on the right hand side, antifibrinolytics are indicated, and here platelet administration is warranted. So it's great because almost immediately and visually we can see what the situation is of the coagulation and the fibrinolysis of a patient, and it saves us a lot of time because otherwise the blood tests have to go to the laboratory and we have to wait for the advice of the hematologist. Blood transfusion, important that we realize that blood transfusion is still administering a drug with its specific risk. After a postpartum hemorrhage, we would only administer red packet cells if the woman is symptomatic, so she is tachycardic or dizzy, and her hemoglobin is less than 7.0 millimole per liter, and we would administer 1 unit at a time. So there's a great learning source, and you see the direct link here. It is the Blood Safe learning webpage. Then complications. What are complications of massive PPH? First and foremost, of course, the disseminated intravascular coagulation, DIC. And when you do investigations, you could see that the platelets are low due to consumption. There is low fibrinogen level in the serum as well, due to fibrinolysis. However, the serum D-dimer level, so the fibrinogen degradation products, are high, and we can see increased prothrombin time and INR due to consumption of clotting factors. So these things we can find out sending blood to the laboratory, and our ROTEM machine gives an answer to all these 4 items almost instantaneously. Other complications is, first is the acute renal failure, acute tubular necrosis. That's seen quite commonly if the woman has lost more than 2 or 2.5 liters of blood, but usually is self-limiting. After a stage of oliguria or anuria, the patient will have polyuria, and the kidneys usually recover without having to revert to dialysis. Sheehan syndrome is a specific syndrome which is due to massive PPH, and it's the consequence of anterior pituitary gland, which was already slightly enlarged due to the pregnancy, which is infarcted. And the last consequence, and the most feared, is of course maternal death. As we discussed at the beginning of part 1, major cause of maternal mortality in the world and very low in resource countries, in low resource countries. In high resource countries this is very rare, and usually a mother would die if there was a delay in the treatment, in the management. So if we did not start to resuscitate promptly and take the various steps as we described before. Sheehan syndrome, that means acute hypopituitarism after a massive PPH. So it's specific for the situation after massive PPH, and it means there can be a complete or partial loss of the anterior pituitary functions. So the endocrine symptoms can vary. It could be a deficiency of growth hormone, prolactin, this is the most common variant, cortisol, so the adrenal gland, thyroid stimulating hormone, and the LH and FSH. So it can occur in every imaginable combination. The early symptoms are failure of lactation, so that should raise the awareness. The failure of hair growth, for instance, if the pubic area was shaved to be for the cesarean section, you will find out that it is not, the hair is not growing. Or poor wound healing after cesarean section, because we need a growth hormone as well for wound healing. And generalized weakness. So very rare, but only after massive PPH, and usually when the patient has been subconscious for a while and had anuria for a while. Then last but not least, the human dimension. When managing a postpartum hemorrhage, it's paramount, essential, that we always keep explaining to the patient what we are doing. She might be subconscious and she might have her eyes closed, but her ears are widely open. And patients tell us that. She has, as it were, elephant ears. Whatever we say will be picked up by her. So, I think we should always encourage her. Stay with us. Don't give up. You lost a lot of blood, but we're dealing with it. Also, I think holding her hand gives a very powerful message that she's not alone. And many patients have told me how they felt supported by these two simple steps. Women sometimes have a near-death experience, which can result in a post-traumatic stress disorder. And we should always remind that the partner sometimes is even worse off. If his wife was subconscious, she would not have witnessed part of the drama. He has witnessed what is quite often, let's be honest, a horror scene with blood on the floor, people running in and out of the labor ward. And so an open door, but debrief as many times as he or she would want us to, is an essential part of being a caring doctor, a warm-hearted doctor. So let's summarize now. Postpartum hemorrhage, after we have taken the usual steps of resuscitation, Dr. ABC, with particular focus on the circulation, we firstly will deal with the lack of the tone of the uterus, because that's the most common cause of PPH. We can mechanically rub up the uterus or compress the uterus manually. We have a number of drugs available: syntocinon, ergometrin, a combination of the two, or prostaglandins, which we can administer usually IV or IM. Sometimes, if the bleeding persists, it's useful to insert a balloon inside the uterus, which we fill up with 400 or 500 milliliters of lukewarm water, and that gives pressure from within, which could compress the blood vessels and stop the bleeding from that point of view. More advanced method would be compression by placing the P-Lynch brace or compression sutures, and vascular tie off the uterine or the internal iliac arteries. Then the second step would be tear or trauma. For that warrants examination under anesthesia, suture the various tears, deal with hematoma, and if we go more to the right hand side, we can see intervention radiology is sometimes an advanced method which can avoid a laparotomy to deal with a massive PPH. The third T is the T of tissue, EUA, examination under anesthesia, and with our fingers or our hand we can inspect the uterine cavity and find out if there are still parts of the placenta present or if there is a uterine rupture. If we go complete to the right, if all steps have failed, usually the life-saving measure is a hysterectomy. A dramatic decision, especially if it would be the first delivery and the first baby, but sometimes it's necessary to save her life. The last group of measures are dealing with the thrombus, with the clotting, and that means replace red packet cells if need be, administer fresh frozen plasma, cryoprecipitate, etc. Now we move to DAROGA. Today, as we speak, it's wonderful to realize that we have now, after 1 year, more than 16,400 views and 140 people around the world subscribe to DAROGA. And that's for me a very positive and humbling experience. If you would like to subscribe to DAROGA, here is the general link, which will give you access to the DAROGA lectures. That concludes Postpartum Hemorrhage Part 2. Thank you for listening. And here is a nice picture of last week when we had a few students at my place and they were practicing OSCE exams for the end of year exams here in Adelaide. And of course, most importantly, they were very relaxed because of the pleasant presence of Jimmy, the Zen Master of DAROGA. Thank you once more, and I trust you learned a lot. Cheers.